Good morning, everyone. I would like to thank the organizing committee for giving me this opportunity. Well, my topic is meningitis and encephalitis. So, it will be mainly a case based discussion. So, I would like that everyone gets involved. So, taking our first case. So, a 25-year-old college student who lives in the campus dormitory presents to the emergency department with fever and stiff neck that began a few hours earlier. He also describes a headache and nausea that started at around the same time. His past history is not significant, and his social history reveals periodic alcohol ingestion. On physical examination, he is a well nourished individual who appears confused. And vital signs are temperature of 103 degree Fahrenheit, heart rate around 120 beats per minute, blood pressure of 95 by 60, and respiratory rate of 20 breaths per minute. A petechial rash is also noted on his tongue. His skin is cold and clammy. And Kernig and Brudzinski signs are positive. So he is oriented to time, place and person, but not to time, and has no focal neurological deficits. Rest examination is normal. So, based on this history and examination, any guess what is the most likely diagnosis you can suspect of? Okay, like everybody is saying meningitis. Why? Because I mentioned fever, headache, neck stiffness, and मतलब Kernig and Brudzinski sign almost are synonymous with meningitis. But for the sake of discussion, let's go step by step. So, okay, first of all, yes, the symptoms are very much typical of meningitis. So, it's an infectious etiology. Second, if we see he is complaining of headache, neck stiffness. So, it can be a musculoskeletal cause. Fever can be due to pain itself. And lastly, patient has come with altered sensorium, headache. So, it can be some neurological cause like subarachnoid hemorrhage. So, the differential diagnosis could be a cervicogenic headache, a migraine, a simple benign migraine can also manifest like that, or emergencies like subarachnoid hemorrhage or meningitis. But since our patient has a classic triad of fever, stiff neck, altered mental status, so most likely we'll suspect infective meningitis. But these three classic triad symptoms are only present in 44% of cases. So, in real clinical scenario, the situation might be different and we have to consider all the differentials. However, almost all patients will have at least two of these three signs. So, meningitis is a medical emergency. It has a mortality of 25% and morbidity of 60%. The usual clinical features are fever with altered mentation, neck rigidity, focal nerve palsy may be present, seizures may be present in 5% to 20%, 28% of cases. And presence of seizures itself is an independent predictor of mortality. Patients who come with seizures have a high mortality around 34%. Systemic complications may be present in 22% of cases. These can be patient can come with septic shock, pneumonia, DIC. On physical examination, Brudzinski sign and Kernig sign may be present. Brudzinski sign is passive. On passive neck flexion, there is flexion of the hip and knees. And Kernig sign is with patient supine. If you flex the hip, there is extension at the knee. The patient will have pain at the back of the thigh or low back. Now, what exactly are these Brudzinski and Brudzinski sign are due to? Yeah, because these are protective reflexes. The patient tends to prevent the movement of spinal cord against the inflamed meninges. So we all know that these signs are present in meningitis. Any other conditions where these signs may be positive? SH, very good. Even in a prolapsed intervertebral disc, patients with multiple sclerosis, these signs may be positive. So they are not 100% specific for meningitis. Again, the patient may have petechial rash, On fundal examination, papilloedema, retinal hemorrhages may be present. Focal neurological deficits may be present on neurological examination. So, what is the differential diagnosis of petechial rash? Our patient was having that. So, petechial rash is a rash which is made up of flat, non-blanching, reddish purple dots which are less than 2 millimeters in diameter. So, if the spots are more than 3 mm in diameter, they are called purpura. So, the cause of rash can be infectious like Rocky Mountain spotted fever or meningococcal meningitis. Autoimmune diseases like ITP, immunoglobulin A vasculitis, coagulopathies like DIC, sepsis, malignancy or minor trauma. So, what is the cause of rash in meningitis? Toxemia. Endotoxemia causes leaky vessels, and actually what we are referring is to rash are like blot-like hemorrhagic spots. Or patient may be in advanced sepsis and going into DIC. So, based on his symptoms, examination, you have concluded that yes, our patient is having infective meningitis, but you need to confirm that, and you also need to keep differential diagnosis in your mind. So, you need to work up the patient. So, what investigations you can do? You can do a CBC to know the WBC count, platelet. They will be increased in infection. He is having purpuric rash. So maybe he might be having thrombocytopenia, or you should do a coagulation profile along with D-dimers to rule out coagulopathy, DIC. And the most important, lumbar puncture should be obtained. You should always rule out the risk for herniation to assess the opening pressure, cell count, CSF, biochemistry, culture and cytology. A CSF PCR panel for CNS pathogens should be obtained, and at the same time blood culture should be sent. So before performing a lumbar puncture, you should rule out the contraindications, which are presence of focal neurological signs, presence of papilloedema. These are signs of raised ICP, continuous or uncontrolled seizures, Glasgow Coma score less than 12, or patient in severe sepsis, or patient on anticoagulant therapy or antiplatelet therapy, or known thrombocytopenia or clotting abnormality. So coming back to our patient, so a CBC was performed which showed WBC count of 18,000, platelet count was 90,000, his coagulation profile was like borderline deranged, D-dimers were elevated, and CSF opening pressure was 250, it was again elevated, and CSF has a yellowish cloudy appearance. On CSF analysis, WBC count was elevated and predominantly neutrophils were present. Protein was 200, glucose was markedly decreased, and CSF gram stain shows gram-negative diplococci. So 6 hours later again a CBC was repeated, and now the WBC count has increased to 22,000. Platelet count has come down from 90 to 40, and repeat coagulation profile had showed markedly deranged coagulation profile, and D-dimers have increased, and his fibrinogen level is only 0.1. So what is happening with this patient? Very good. Yeah. So the patient has acute gram-negative. We know that it's a gram-negative bacterial meningitis. Most likely the patient is in sepsis and has a consumptive coagulopathy. So which organism is the most likely culprit? Well, all the features including history, physical examination, presence of rash, gram stain, we can conclude that he has a Neisseria meningitis, but we need to confirm by culture or CSF PCR report. So Neisseria meningitis is an encapsulated gram-negative Diplococcus bacteria with several serotypes. That it's a colonizer of nasopharynx. So this patient who is living in a dormitory housing most likely would be exposed to a strain of this Neisseria, and that he was not immune to. So other risk factors for developing meningitis are patients with asplenia or complement deficiencies. So coming to etiology of infective meningitis, it can be a bacterial pathogen, fungal, viral or tubercular. So broadly, bacterial meningitis can be a community acquired meningitis or nosocomial meningitis. Community acquired, the common pathogens based on age are very young patients, less than 2 months. It can be a group B streptococcal infection or streptococcus pneumoniae, listeria or E. coli. And from 2 months to 23 months, streptococcus pneumoniae and meningitis, H influenza type B or group B. In young patients, again as in our case, it can be N meningitis or streptococcus pneumoniae. And elderly patients, it can be streptococcus pneumoniae and meningitis, Hib, group B streptococcus and listeria. And the other is nosocomial, patients who have undergone neurosurgical procedures, patients with implants like EVDs, they are susceptible to Staph aureus or gram-negative bacilli or coagulase negative staph. Patients with bacillus skull fracture may develop streptococcus pneumoniae or beta hemolytic streptococcal meningitis. So why we should know? Because we have to start the specific antibiotic treatment. So we should be knowing the etiology based on predisposing factors. The other cause can be a viral meningitis. Enteroviruses are the most common cause of viral meningitis across all age groups. Followed by HSV1 and 2, varicella zoster virus, CMV, Epstein-Barr virus and human herpes virus 6. Other viral causes include adenovirus, lymphocytic choriomeningitis virus, influenza, parainfluenza and mumps. Arboviruses that can cause viral meningitis include West Nile virus, chikungunya and dengue. Fungal meningitis, Cryptococcal neoformans is the most common etiologic agent, and mainly you see fungal meningitis in immunocompromised hosts like patients with advanced HIV or recipients of solid organ transplants. Cryptococcus gattii is an emerging fungal pathogen and it can cause meningitis even in immunocompetent hosts. Other fungus like Coccidioides, Histoplasma and Blastomycetes, these are endemic to particular geographic regions and can cause meningitis. Now tubercular meningitis, TB, Mycobacterium tuberculosis generally causes a chronic meningitis in which the symptoms and evidence of meningeal inflammation are present at least for 4 weeks, and it occurs in around 1 to 2% of cases of active tuberculosis. So I hope I am clear till now. We know that the etiology of meningitis can be bacterial, viral, fungal and tubercular. So let's take our other case. Now this is a 59-year-old male, hypertensive, diabetic, and he presents with history of fever and altered sensorium since 2 days. And he also had 2 episodes of seizures in between. On examination, he was somewhat arousable to verbal stimuli but had expressive aphasia. An initial lab showed neutrophilic leukocytosis, mild, borderline, mild hyponatremia of 134 and HbA1c of 12.4%. So based on his symptoms, because he had predominantly neurological features, an MRI was done. So the MRI brain axial T2 flare showed this image. So what are the findings? Yeah, increased hyperintensity in the left frontal, parietotemporal and right frontal and insular regions. Okay. So brain parenchyma is showing some hyperintensities. So any guesses? What do you suspect? No, don't go to the organism. What is the illness exactly? Patient has come with some symptoms: fever, altered sensorium and focal neurological deficits plus history of seizures. His encephalitis. Very good. So meningitis is inflammation of meninges. When the infection involves brain parenchyma, it is encephalitis. And so based on MRI, the CSF examination was done. With the CSF was colorless and clear. WBCs were mildly elevated. Glucose was almost near normal. Proteins were elevated. So the PCR showed HSV1. So it was a HSV1 encephalitis. And the gram stain and bacterial culture did not reveal anything. So encephalitis is a predominantly infection of brain parenchyma and most commonly caused by a viral etiology. So most commonly HSV1, CMV, varicella zoster virus are the causes. Other viral causes are mumps, enterotoga virus, lymphocytic choriomeningitis virus. So the common clinical features are of the patient gives history of a viral illness, a prodrome of viral illness followed by neurological symptoms like change in level of consciousness, presence of focal neurological deficits, or presence of seizures. So three main forms of encephalitis are seen: HSV encephalitis, varicella zoster virus encephalitis, and West Nile virus encephalitis. So herpes simplex encephalitis is the most important form of treatable encephalitis. Presents with altered consciousness, loss of memory, personality changes. Patient will present vague symptoms, not typical of like you see in meningitis. Confusion, aphasia, amnesia, olfactory hallucinations. When brainstem is involved, diplopia, dysarthria, ataxia may be present. Sometimes you will see herpetic rash, not always. So again, it's a medical emergency, has a high mortality. Even after treatment, patient may have cognitive and behavioral disorders. Post-treatment seizures will be there. Post-infection encephalomyelitis may be present. HSV virus has a propensity for temporal lobe. So often the MRI will show hyperintensity which involves the medial temporal lobe, or you can also see hyperintensity in the left insula or anterior aspect of temporal lobes. Varicella zoster encephalitis is the second most common cause following the HSV, and often it occurs due to reactivation of latent infection in immunosuppressive conditions. Sometimes it may also occur in immunocompetent subjects. So clinical signs again: fever, headache, nausea, vomiting, acute disturbance of consciousness, seizures, and meningeal irritation signs like mucorigidity, Kernick sign may be present. But since it's involvement of brain parenchyma, patient may present even with motor paralysis and sensory disturbance. West Nile virus encephalitis mostly seen in elderly patients, and it has a mortality of around 15%. Again, similar features may also present with myoclonus, cerebellar signs, chorioretinitis and uveitis, rhabdomyolysis, and in severe cases, patient may also present with acute flaccid paralysis because of involvement of anterior horn cells. This shows again hyperintensity in different parts of brain. So now you are presented with a patient who you are suspecting to have infective meningitis. We have already discussed the probable etiological agents. Now how to evaluate? You need to differentiate whether these are bacterial meningitis, viral meningitis, and ultimately you need to conclude which organism is causing the infection so that you can start definitive antibiotic treatment. So most important, as we have already discussed, is the CSF analysis. So this table shows the findings. You have to evaluate the opening pressure, WBC, presence of polymorphonucleoleucocytes. In bacterial meningitis, you will see the opening pressure is always very high. WBC count is markedly increased with predominance of neutrophils. The glucose and protein are decreased in almost all meningitis except for viral etiology. Again, protein is increased in all. You will see proteins are not significantly increased in viral meningitis. Gram stain may be positive in bacterial meningitis. Cytology can be positive in neoplastic or fungal meningitis. You will see budding yeast cells. So this is very important. and the report you can get immediately. So you can get to some conclusion कि okay, this is the most probable cause. So CSF blood glucose to CSF glucose to blood glucose, if the ratio is less than 0.4, has a 98% specificity for bacterial meningitis. So decreased blood glucose occurs in almost all, but if the ratio is less than 0.4, then you can be sure that it is bacterial. And more specific for bacterial meningitis is CSF lactate levels. Levels of more than 4 millimoles per liter again has a specificity of 98%. Again, you can be sure that the etiology is a bacterial agent. In tubercular meningitis, now this is difficult to diagnose. AFB staining is only positive in 30% of cases. So rest of the cases you have to depend on your molecular diagnosis, that is nucleic acid amplification tests. What we do in our hospital is gene expert for diagnosing mycobacterium and also to differentiate it from atypical mycobacteria. So now I have already discussed that it's a medical emergency. Now you need the report like say within few hours to come to start your antibiotic. Otherwise, most of the cases, as soon as the patients arrive and you suspect infective meningitis, you have to start empirical antibiotic therapy. But still you need the report so that you can switch over to definitive treatment. So recent advances, we have various investigations where you can get the reports quite fast, like say within few hours. So such tests are rapid antigen assays, serology like IgM, IgM and IgG for encephalitis, for neurosyphilis, and molecular methods most important are polymerase chain reaction based multiplex assays or a MALDI test. Now what is MALDI? MALDI is a matrix assisted laser desorption ionization test. It's based on mass spectroscopy, and this also can give results like within few minutes even what they said. So for diagnosis of common bacterial and viral pathogens, so you can do a rapid meningitis panel test which is PCR based, or you can do a MALDI test which is based on mass spectroscopy and differs which from center to center. So this PCR is basically a nucleic acid amplification tests. Again, gene expert can be used for mycobacterium, and again molecular assays can be used for diagnosing Japanese encephalitis. So at Medanta, we do routine CSF gram stain, AFB stain, culture sensitivity, and we do rapid antigen assays and a rapid meningitis panel. Now, in difficult cases where the diagnosis is not sure or patient has already taken some antibiotic treatment, then rapid meningitis panel is of great help. Gene expert again for TB. So one such test is a BioFire meningitis encephalitis panel. It's a multiplex PCR. It's a FDA cleared test, and it targets 14 of the most common bacterial, viral and fungal causes of CNS infections. So just you need a very small sample, around 0.2 ml of CSF and an R to deliver. That's what the company says. We do it, and generally we get reports within less than 4 hours. So it has overall specificity of 99.8%. So the common bacteria which it detects are E. coli, H. influenza, Listeria, Neisseria, Streptococcus, pneumonia, and Echinacea fungal for Cryptococcus, and common viruses like CMV, HSV 126, enterovirus, varicella zoster virus. Coming to the next part, imaging. So imaging is not exactly required for diagnosis. It is usually done when we are in doubt or to diagnose complications or sequelae of meningitis. So we have two options: go for a contrast CT, as we all know it shows leptomeningeal enhancement, or we can go for MRI. MRI is more sensitive and gives results slightly earlier than the CT scan. So on imaging, it can be entirely normal scan, or you can see hydrocephalus, enlargement of CSF spaces, poor visualization of basal systems, generalized cerebral swelling, diffuse meningeal enhancement, communicating hydrocephalus, subdural effusion, or focal high signal parenchymal abnormalities, which we have already seen, and sometimes complications like infarction can also be detected. So MRI is superior to CT. It detects the changes earlier as compared to CT scan. So we have already seen the FLAIR images which can show leptomeningeal enhancement or CSF hyperintensity, and this hyperintensity is due to increased protein content. So coming to the treatment, so if you are suspecting meningitis, start empirical therapy and start as early as possible. Don't wait for CT scan or CSF confirmation. You have to consider the most likely organisms involved, and which depends upon patient's age, immune status, community acquired or nosocomial. If in our case, if we are managing patients in neuro ICU, usually we see meningitis in post-operative patients, patients with EVD, patients with head injury. So the flora is coagulase negative staph, gram negative streptococci. So we have to consider those antibiotics which target specifically these organisms. So based on age, the empirical treatment will be like young patients. We have already seen the common pathogens are S. pneumoniae, Neisseria, Haemophilus. So the preferred first line would be a third generation cephalosporin along with vancomycin. If the patient is allergic to cephalosporins, we can give meropenem or chloramphenicol or moxifloxacin. In elderly patients, there is a risk for listeria meningitis. So we add ampicillin, which targets listeria. So ampicillin plus vanco plus ceftriaxone is the first line treatment. Patients who are immunocompromised again are at risk for listeria, gram-negative bacilli, streptococcus pneumoniae, and Neisseria. So again, MP plus vancomycin plus ceftazidime or cefpime. If the patient is allergic, then we can give meropenem. In our cases, like post-surgical patients, patients with trauma, suspected infected shunt patients, the bacteria responsible are usually a coagulase negative staph, Streptococcus pneumoniae, gram-negative bacilli. So you can give vancomycin plus cefepime or vancomycin plus meropenem. Generally, we start in our ICU vanco plus meropenem because most of the organisms have become resistant to the cephalosporins. So pathogen-specific recommendations, again Streptococcus pneumoniae, first line would be penicillins. If the patient is allergic or resistant, then you go for meropenem. If Streptococcus pneumoniae, the MICs are more than 0.2, then you go to cephalosporins or alternatively meropenem. And if the MICs are still more than 0.6 for ceftriaxone, then directly you will go to vancomycin plus ceftriaxone. Or even you may have to add rifampicin for resistant cases. For Neisseria, penicillin is the first choice, or alternatively you can start with ampicillin or third generation cephalosporins. H influenza, again ceftriaxone or cefotaxime. For Listeria, ampicillin is the drug of choice along with gentamicin. Group B streptococcus, penicillin or ampicillin is first choice, or alternatively you can give vancomycin. The treatment duration is generally 2 weeks. It may also get prolonged to 3 weeks. For nosocomial meningitis, gram-negative Klebsiella, Pseudomonas, you can give ceftriaxone or cefpime or meropenem plus gentamicin or Ciplox for 14 to 21 days. For Staph aureus and Staph epidermidis, nafcillin or oxacillin is the choice. Alternatively, you can give vancomycin plus rifampicin. For MRSA, vancomycin plus rifampicin, or if allergic to vanco or vanco is contraindicated, then you can give linate or daptomycin along with rifampicin. For tuberculosis, you need to give 2 months of intensive phase of HRZDF and 10 months of continuation phase with HR. And there is also role of steroids, tablet prednisolone 1 milligram per kg OD for 2 months, and then it is given in this dose for 1 month and then tapered over the next month. Viral meningitis treatment is supportive. Specific antiviral therapy for HSV is acyclovir 10 milligram per kg 8th hourly. For CMV is ganciclovir plus foscarnet. For West Nile it's acyclovir again. One point to note is that we have discussed the infective encephalitis. Well, there can be non-infective causes for encephalitis like immune-mediated encephalitis, acute disseminated encephalomyelitis, paraneoplastic or voltage-gated K-channel limbic encephalitis. This you can read later on. So for fungal meningitis, initial induction phases for 2 to 6 weeks with an amphotericin based regimen. Chronic suppressive phase 6 to 8 weeks with a triazole derivative. For example, fluconazole or voriconazole is indicated. You have to manage the risk factors like hyperglycemia, and you may have to minimize the immunosuppressant dose whenever possible. So amphotericin B is given in a dose of 1 milligram per kg IVOD. Flucytosine can be given 25 milligram per kg orally every 6 hours. So patients who have renal insufficiency, then you might use liposomal amphotericin or amphotericin B lipid complex. Newer advances include voriconazole, echinocandins, but they don't have as good CNS penetration. Usually these are reserved for candidial infections. Intrathecal amphotericin B, generally given along with flucytosine in patients who are not responding to systemic antifungals. Steroids for meningitis, as per ITSA guidelines, you have to give steroid to decrease the sequelae. The steroids have been known not to decrease the mortality, but post meningitis sequelae like hearing loss or neurological complications. So they should be started just prior to or along with antibiotics. The usual dose is recommended is 0.15 milligram per kg every 6 hours for 2 to 4 days. TB I have already discussed. Prednisolone can be given for 2 months. Then role of intraventricular or intrathecal antibiotics. These are reserved in patients who are difficult to treat with resistant infections or who have like EVDs in place where you can easily give the antibiotic through the EVD. These have to be preservative free solutions, have to be injected slowly. The potential adverse effects of giving intrathecally can be ototoxicity, seizure, altered mentation or local tissue irritation. So the common antimicrobial agents which can be administered by intraventricular route are amikacin, amphotericin B, colistin, daptomycin, genta, polymyxin B, tobramycin and vancomycin. Almost we have used all antibiotics intrathecally. So coming to our last case, so this is a 45-year-old male post RTA, had injury 15 days back. History of EVD placement and some antibiotics he has taken. He now presents with fever, neck rigidity, altered sensorium and seizures. So CSF analysis shows increased WBC count, but 50% are lymphocytes. Glucose is 60 and protein is 120. His CSF lactate is increased. Procal is 25 and gram stain does not show anything. So first of all, now you are given one investigation. You can do one investigation in this patient which will lead you to diagnosis. So what will be that?
CSF glucose upon blood glucose.
Glucose is 60, so I think the ratio will be more than 0.4. It's not less than 0.4. Glucose is not very much decreased. One investigation that you can send to diagnose. I have already discussed. Biofire you can do, na? You can get accurate result within 4 hours. So So it can help you giving the diagnosis. And what is the most probable diagnosis just based on this thing? Partially treated. Very good. Because it's a case of head injury who has taken some antibiotics, he has a EVD in place. So he has some foreign body. And usually the partial treated meningitis comes with such picture, and two other indicators are his CSF lactate are increased, which is another indicator for bacterial pathogen, and procal is 25. So again a bacterial infection. That's it. Thank you.